Laveaga from the University of California, where she is Associate Professor of History. Dr. Laveaga has written several books, including one on jungle laboratories, which won a prize, an important prize in scientific writing in 2010. She's working on a book on the physicians' strike in Mexico, and more recently she's been doing research on the scientific relations between Mexico and India. She'll be talking today on the theme of today's seminar, which is Mexico, uneven development and primary healthcare. Dr. Gabriela.
Okay. So first, I want to thank all of you for being here today, and I'm especially grateful to the organizers for creating such an interesting space where we can debate and dialogue about ideas. And I'm looking forward to your comments and questions at the end of my talk. Today, I'm going to use two case studies to speak about Mexico's historical approaches to primary health care. With these two cases, I wish to illustrate how a country with a poverty rate that throughout the 20th and 21st century hovered above or slightly below 50% has at different moments in its past implemented various models of healthcare, some of which might look familiar to those of you interested in global healthcare models of the late 20th and early 21st century. If we take a look at this map of Mexico, and then we superimpose a map of extreme poverty in Mexico, what we see is that in the south and the southeast regions of Mexico is where most of the extreme poverty is to be found, and in particular, and also in the central area of Mexico. That is taken from the 2010 census. If we then look at a map of where indigenous languages are spoken in Mexico, not coincidentally, it happens to be the same regions where we find the extreme poverty in Mexico. So in Mexico, these areas in the past have been figuratively worlds apart because of distinct language and cultural traditions, but they have also been quite literally difficult to get to regions. Several of Mexico's attempts to provide healthcare will be concentrated in these areas, and I will be referring back to these maps. So in today's brief talks, it's structured with a historical background. I will also give two examples of Mexican solutions to unequal access to healthcare, one from the 1930s and another from the 1970s. And I will conclude by looking at what can these two historical cases teach us about approaches to global rural health. So I want to take us briefly to the beginning of the 20th century, when Mexico greets the new century with a bloody revolution that begins in 1910. It will claim the lives of more than 1 million Mexicans. Over 1 million other Mexicans will flee to the United States, and it will take more than 3 decades to recover from the population loss caused by the political and social upheaval. But in the midst of this turmoil, a new constitution is drafted. And it's here where I want to get one of the first points across of this talk. The Constitution is drafted when there is still active fighting happening throughout the country, but various factions are called together to sit at the table to write up this document. And by all factions, I mean workers, peasants, businessmen, landowners, the military, and politicians. This fact is important because this means that the Mexican Constitution of 1917 has social guarantees that may well not have been put in place had, say, lawyers in the majority at the table. So many of the rights protected in the Constitution were put forth by the working class and by peasants. So we have contained in this document, for example, extraordinary labor laws. Peasants receive the right to land, and all Mexicans are guaranteed the right to free education, among other rights. And of course, the Constitution addresses the question of health. As we all know, however, what is written on paper, especially a Constitution, is often difficult to translate into reality. So in the Mexican Constitution, it says that all persons have the right to the protection of health. But at the time that this is written, Mexico does not have healthcare services in place. Remember, it's in the middle of a revolution. So the promise of healthcare is there in the document, but there is no concrete plan for how this healthcare will be delivered. Health then rests in the labor laws, Article 123. And Article 123 states that an employer is responsible for ensuring the health and safety of his employees. But again, there are still no institutions at this time that would provide this health care. And especially, the Constitution doesn't say anything about those who are not part of the labor force. By the early 1930s, the country has found stability and peace from fighting. And in 1934, a populist president, Lázaro Cárdenas, comes to power and sets about to implement the social guarantees that had been established nearly 20 years earlier in the 1917 Constitution. While he's best known for education and land reform, his administration's focus on health is the first of my two examples. During Cárdenas's time, Mexico's total population was approximately 18.5 million, and the leading cause of death for Mexicans at that time was linked to diarrhea or gastrointestinal problems, most commonly associated with the lack of potable, clean water. These deaths speak to preventable diseases and deaths caused by lack of basic infrastructure. But rather than address inadequate housing, unpaved streets, or lack of sewage, politicians begin to ask themselves about the delivery of care. And in particular, the barrier to fighting illness is translated as a lack of doctors and not a lack of infrastructure or disparity between the wealthy and the rich, the urban and rural. And Mexico did indeed have a significant physician shortage. An often cited number of the time is that Mexico had a rough 4,520 physicians at that time. Amazingly, almost half, 2,000, lived in Mexico City, and another 1,500 lived in the other main cities, which meant that there were 600 physicians, left for 2,100,000 Mexicans. First, let me repeat that. There is an average of one physician per 21,000 rural Mexicans. That's a huge number, considering the disparity that was in the urban spaces. So in the 1930s, much of the countryside was a recipient of targeted health campaigns, be it disease eradication, vaccination campaigns, or hygiene education. In short, what these campaigns meant was that healthcare personnel was as transient as primary health delivery. And here what we see is in the state of Guanajuato, in that tiny truck in the back, they have a film projector, and they're projecting health films, and they're going from small village to small village. And you can see that the auditory to promulgate the health news from one village to the next. So with those figures in mind, very few physicians, most of them concentrated in urban spaces, the president decides to do another decree. And in 1936, he decrees that every medical student will have mandatory social service for anyone interested in the health services. What this meant was that the reforms to health, and in particular to health care, to medical education, would be infused with the sentiment of social obligation, which was common to the period. And in that spirit, the president made two major changes. This one, the decree that was later written into the Mexican Constitution, declared all medical students would be obligated to spend 5 months, today it's 1 year, among the poorest in the country, ministering to the indigenous, but also to the lower classes before they could receive a medical license. The goal was that once licensed, medical students would return to practice among the indigenous and the poor. They were required to send in weekly reports and bi-monthly larger narratives of what was happening in rural areas. But in addition to this, medical students would be not only immersed in the poverty of the majority, but it was also a way to let the state know what was happening in difficult to reach places. Because more than simply being physicians, these future doctors would also be statisticians, census takers, health educators, and the eyes of the state in difficult-to-reach communities. Each medical student would be responsible for submitting a weekly RIP summary, and at the end of 6 months, a thesis that would include the history of the place, the type of population, the climate, eating habits, financial means, and the causes of morbidity in the region. In other words, giving a summary of the areas that the government was not aware of how they existed or the diseases that were in place. And here's a sample from a student from 1936 that included pictures with his summary and with his analysis of the region. There was a problem, of course. These students were often sent with no knowledge of what to expect. They were urban and were sent sometimes solely with medical supplies to live in villages too remote to have roads, and where often Spanish was not spoken. Medical students complained of being confronted with diseases which they had never encountered in textbooks or in medical school. They reported that it was nearly impossible to stop malaria and dengue in regions with no roads, such as this slide. Medical students complained at how badly locals mimicked hygienic behavior, which they had been sent to teach. And they were especially stunned by the poverty of the nation's indigenous people. So, though they often witnessed labor and physical abuse by locals against indigenous population, in sanitary reports, these problems were described in detail, but they were not analyzed. What was plain to the doctors, however, was the despair of the people, and more importantly, their own despair at finding that they could not readily institute health solutions. So these are just some examples pulled from various reports from 1948 and 1950. A single isolated person cannot be successful in this terrain because the problem is a lack of hygienic knowledge that goes beyond what one can do during social service. The general appearance of this town is depressing. Another said, "My efforts here are useless." And the reports vary. Some listing successes. A constant was the disdain that medical students had for local healers, which doctors had been taught in their medical schools represented the backwardness of Mexico. Not surprisingly, the majority of medical students returned to the haven of urban lives after their few months in the countryside. Attempting to remedy this situation, where it had initially been planned for medical students to stay in these areas, in 1938, the second innovation to medical training in Mexico happens, and President Cárdenas again issues a decree where he initiates a new major at a new medical school in rural health and campaigns to bring rural students from the areas where doctors did not want to live in to urban spaces to train them so that they will go back to their towns of origin and practice medicine there. That doesn't work either. Many of those rural students who come to urban spaces decide to stay there as well. So we have this gap between the guarantees of the Constitution in 1917, which promises and says that health care is available for all, but despite these attempts, there's still a lack of physicians in these rural areas. So despite that 1917 guarantee, it's not until 1943 that the Mexican Institute for Social Security, or IMSS, is founded. And this institution grants the Mexican government the leading role in the provision of health services. The IMSS health system, as originally conceived, was quite simple. Employers would pay into government-run clinics and hospitals, and workers would enjoy medical benefits at little or no cost. Within a few years, the IMSS had expanded from a few clinics housed in factories into hundreds of health units throughout Mexico. The system, however, had one glaring omission. Most of its beneficiaries were urban workers. Little state medical attention was provided for non-industrial rural workers, such as cane workers, rubber workers, or farmers. Even less care was made available for rural women, infants, and children. So to give an idea of the complexity of Mexico's healthcare system, the private sector, which is divided there, and the IMSS, which I just spoke about, is the first in the public sector health institutions. ISTE, which is another health institution, is only for bureaucrats, and then there's parastatal institutions. And then you have individual public firms with their own health institutions, clinics, and hospitals. For example, if you're an employee of Pemex, the petroleum behemoth in Mexico, or if you're a member of the Army and the Navy, you go to different health services, which left the Ministry of Health to provide health care for those who were dependent, who could not pay into the system. And the one that says other, those are recent, as of 2000. So what we have in Mexico is, in the 1960s, this idea that poverty is a problem that in Mexico had not been discussed, but becomes very public when this book comes out and begins to question the development of Mexico. Because Mexico had been touted as the Latin American country that was on a path to fast-paced industrialization and development. But by the 1960s, it becomes clear that what had been called the Mexican miracle is a myth. And behind that facade is a broken social pact where the promises of that famous constitution had not been kept. And people begin to ask, what happened to those social guarantees? And it's at this time, in 1973, in response, that Social Security laws were modified to extend benefits to groups without the ability to contribute. And those without the ability to contribute were, of course, those in rural areas, in what came to be known as social solidarity. Of all services tackled by social solidarity, medical care for all seemed the most elusive. So in 1974, Mexico begins a series of programs, and they all have the notion of solidarity. So solidarity for community cooperation, in which, in turn for receiving services, the community would help, for example, to build the clinic, or help care for gardens that had medicinal plants. But it isn't until after the Alma Ata Declaration, in which it's a guarantee health care for all, that Mexico creates a program that is my second example, and I will quickly turn to that. This notion of social solidarity will go beyond the urban spaces, and it will create with IMSS, that health institution that was mainly for urban workers, it will create IMSS Coplamar. And Coplamar meaning for those in underserved spaces. Do you remember that initial map? That is where initially Coplamar will be anchored. So to do this, Mexico has to study what health means in the area. And it turns out that quantifying disease and even health in Mexico becomes a very difficult task. Do you remember that graphic with all the different institutions? Well, Mexico sets out to compile information about the nation's health and health services, but was receiving contradictory information from health and welfare services, depending on which agency was asked. So for the following 3 years, into the field will be sent anthropologists and sociologists to detail the level of healthcare in these areas. What will come out will be 6 volumes, and this is the one on health. And they decide that in order to tackle that very large problem of poverty in Mexico, they have to have a multi-pronged approach. They have to look at education, they have to look at nutrition, at housing, but especially at health. And the way in which they're going to do it is to look at the history of what has failed in the past. Do you remember those medical students going to the rural areas and deciding not to stay, and try to implement something different with the ideas, these global ideas, but creating a definition of what health and poverty mean for Mexico, not an imported notion of poverty, not a global definition of health, but a definition that pertains specifically for Mexico's spaces. So seeking to remedy the disparity between those who had access to health and those who did not, in January 1977 is when another president launches the Plan for the National Coordination of Depressed Zones and Marginal Groups, commonly known as Coplamar. According to its founding chapter, Coplamar would focus broadly on the establishment of social solidarity, there's that word again, social solidarity projects in the country, especially in the marginalized zones. But these projects had loftier goals than poverty alleviation, They were designed to bring basics of social welfare to marginal regions with the intent of providing the needed infrastructure to incorporate these areas to the rest of the country. The first goal was to understand what lack of health meant and what poverty actually looked like in Mexico. So this book becomes the authoritative guide filled with facts and figures about how many people had dirt floors, how many people had meat once a week, twice a month, 3 times a month. And it's these statistics to begin to define what the notion of health, but also of poverty means in this specific context. And more importantly, they decide that in order for health programs to work in Mexico, in those rural areas, they need to incorporate the participation of rural people. By incorporating rural people, especially traditional healers, in Coplamar's attempt with one sweep to do away with decades of rural healthcare failures rooted in racial tensions, cultural insensitivity, and lack of feedback. So, for example, just because I know I've covered a lot, just as a summary, in 1979, under Eames, no workers will be covered. Then you have the National Plan for Depressed Zones and Marginal Area Groups, which teams up with Eames to provide healthcare for rural areas. And the goal is to establish in 1 year 2,000 rural medical units in forgotten zones, the indigenous areas. The goal, 52 clinic hospitals in the countryside, and to treat 10 million people. By 1981, less than 2 years later, these goals are exceeded. 14 million people in 3,024 medical units are receiving health care in rural spaces. The key is working closely with the community. And here's the major difference in my remaining minutes. With that large study that had been concluded, they realized that much of these failures to health programs in the past had not interacted with people. There had not been a dialogue with people on the ground. So with those doctors and nurses involved with Coplamar, they decide to ask patients what they need. And here's this wonderful example. And these pictures, the following ones, were provided to me by Dr. Roberto Campos, who was a physician in the early 1980s as part of these Coplamar clinics. And here you have this woman from Campeche, which is in the tropical humid zone, very hot, and she's just given birth. And you manage to see that underneath that very thin pillowcase and sheet is a rubber encased pillow and mattress. And when they asked what they needed, she said, "We're not accustomed to sleeping in narrow beds. We grow up, we give birth, we die, we sleep, we live, we make love in hammocks. So why can't we have hammocks in clinics?" Just that simple change would completely alter how we experience childbirth and postpartum situation. And just by simply changing that and by asking women, what do you need? Other changes were creating spaces for alternative healing methods, and especially respect. So what you would have in one building, you would have 2 entrances, and in that building you would have, under one roof, traditional healers, and on the other one you would have Western trained physicians with the respective pharmacies. There's only one of these, and it still exists, but it was the only one that was built in the state of Puebla. And creating a sense of acknowledging local healers and the value that they bring to communities. So they would make conferences, the first conferences that would bring indigenous healers together to speak about their healing traditions, especially incorporating midwives. Do you remember those doctors in the 1930s that disdained the value of midwives? And the way that they incorporate these midwives is by making them the health promoters for family planning. So what you would have was locals as the promoters of health, those who would be knowledgeable, those who already had respect in the community. But more importantly, medical knowledge had to flow in both directions. So you would have these spaces in which physicians and traditional healers were brought together to discuss the power of medicinal plants. So you would have oncologists, gynecologists, dentists, endocrinologists who would come and they would speak, and this seminar is still taking place at the National Herbarium in Mexico City. But they would come together and one might say, my patients come and they suffer from evil eye. And the doctor would say, well, what are the symptoms? And he said, he has incredible thirst, he begins to waste away. You say, well, that sounds a bit like diabetes. What are you giving them? And they would mention the plant and they'd say, oh, interesting. the chemical compounds that you need to alleviate symptoms of diabetes and to really start a frank conversation with traditional healers. So in my concluding remarks, worrying health statistics prompted Mexico to develop and implement health projects specifically tailored to the country's needs. They researched what poverty, housing, nutrition, and education meant in a Mexican context, taking not international models, but looking to their own history of failures and successes in health care programs to begin to understand. They used facts and evidence to devise a program that could be exported to local communities. And this was allowed to happen because in the late 1970s, Mexico had a lot of oil money. But by 1982, Mexico faces its peso crisis. And as part of this peso crisis, Mexico has to do away with a lot of social services. And much of the first funding that's taken out is to projects such as Coplamar. So even though a program that had many problems on the ground, I don't want to paint a rosy picture, it was stopped. The financing was terminated shortly thereafter. But Coplamar survived in other iterations. It became known as Solidaridad Progresa, and now you might know it as a conditional cash transfer program known as IMSS Oportunidades. It has shifted. It did not start as a conditional cash transfer program, and much of the initial goals, but the foundation of Coplamar was started in 1978 to what it is today. So for those of you who know Oportunidades, you know that translated in different iterations to New York, to Brazil. So in my final concluding remark, I just want to say, what can we take away? So in Mexico, the delivery of healthcare to rural areas was very much focused on social obligation response created by a populist president. But the simple increase of medical personnel turned out to not be the solution because medical students were not interested in either staying in rural areas, nor did they understand or respect the cultural differences of their own country. So we need to take into consideration the attitudes of medical personnel. And what Mexico discovers is that without local participation in positions of authority, change in health patterns would not happen. So many of today's on-the-ground recommendations that we have that global institutions have for healthcare delivery were already attempted in Mexico much earlier in the 1930s, the 40s, the 50s, and the 60s. We don't often turn to Mexico as a model of healthcare delivery, but in turning to countries such as Mexico, we raise new questions about the most effective way to deliver healthcare. Thank you so much.
Okay, so I'd like to thank Dr. Gabriela for her talk and ask people to keep their questions for later, because we'll now have our second presenter, who is Dr. Amalia del Riego Abreu, who is from PAHO, from our Washington office in PAHO. She is the Unit Chief of Health Services and Access Units at PAHO. She has worked for more than 20 years in the region as a PAHO staff member in different capacities, including in the sub-regional office in Trinidad. And she has a background in medicine and public health from the Dominican Republic. So, Dr. Amalia, please.
Thank you, and thank you for the presentation. I was actually having a lot of fun with the presentation because I think it really blends very well with what is the history of the region of the Americas and where we are today in terms of the new challenge, or at least revamping challenge of universal health coverage. And I will try to really go through a little bit of the historical perspective taken from Alma Ata in the primary healthcare strategy to today universal health coverage as a path forward in the region of the Americas, perhaps for the world, but I will be taking the regional perspective and trying to situate all of this in the context of the health of the region, the challenges and opportunities, and then where we are as a region in the discussion of universal health coverage. And basically, I would like to start with a little bit of the history. And PAHO, the Pan American Health Organization, was actually founded in 1902. It is perhaps the oldest international public health agency. And then later on, when WHO was created, PAHO became the regional office for the World Health Organization. And then that's why the region of the Americas always is labeled as PAHO and AMRO. And we do have a history behind that. And I want to really take that in terms of the history, there is a long-standing, really, commitment in approach in the member states of our region for collaboration. And the situation, the health situation of the region was the one imposing the creation of the organization in 1902. And it was pretty much related with many things, including the economic and social context at that time. So our countries, our member states have been very vocal in the advancing all of at the regional level and at the global level, the right to health. And of course that we have seen the transition between Alma-Ata in 1978, where basically all of these values that we saw in the previous presentation in one country were put on the forefront at the global level in terms of the essence of Alma-Ata, the right to health, and solidarity. And then we have seen several processes in the region in which we have evolved to even the need for the member states to reaffirm the commitment with the values that were embraced in the Alma-Ata Declaration and in the strategy of primary health care. And around 2005, the member states reaffirmed the commitment with those values in what was called the renewal of primary health care in the region of the Americas. That also was reaffirmed globally when WHO also launched the World Health Report in 2008. And lately, we evolved to the whole issue of universal health coverage as having an additional step forward in the original initial goal of health for all, and then what that means in the 21st century. I want to go a little bit with a little bit of information on the region, where we are, the health gains, the challenges in shaping the future, and maybe start by saying that in the region there have been tremendous changes that will situate the region today with important demographic changes, with an important increase of life expectancy, an important decrease of infant mortality, and also, as you will see, differences between the different sub-regions. That has been also accompanied by important development in terms of social and economic development, economic growth, in an increase in democracy. Democracy has really consolidated in our region with more and more empowerment of people and more decentralization processes that calls for meaningful participation of the population, not only by mandate, but by demand. And I'm going to just show and to highlight the impact in the health situation and in the health gains of all of that development In our region, we were the first region in the world to eradicate polio. We have eliminated measles, rubella. We are really on target in terms of coverage for diphtheria and pertussis. The maternal mortality has tremendously declined in the region. If we take tuberculosis incidence, it's also going in an important decline. Morbidity and the mortality for HIV have reduced significantly due to increase in antiretroviral therapy access to and coverage. And we have important health reforms and responses, which will be a combination of specific health sector responses with also responses in social protection. And I think Mexico is one of the examples of the countries that have done both the health reform accompanied by also social protection, including health. And I have examples of different programs that have been implemented. And as you see, we can take from the poorest country like Haiti with specific interventions to really improve access to services, to Brazil, to Argentina that have really progressed, and Chile with different more comprehensive responses, like, for example, in Brazil, the programs for family health, and then in Chile, what they call the universal access with explicit guarantees. Lately in Brazil, they have even made a bigger emphasis and push for expanding primary care, which continues to be a challenge, especially for underserved and communities. And this is really now an initiative that also embraces collaboration between countries. In this case, Brazil, for example, has launched a program that is called Mais Médicos, that basically is bringing physicians from outside in a south-to-south collaboration with Cuba to really provide services in the Amazon. It's a very controversial program, it's a very controversial initiative, but it's Brazil's way to advance for expanding primary care. El Salvador, for example, have recently introduced an important health reform, basically with strategic components, with integrated health service delivery, which includes all of the elements that we have been discussing about the renewal of primary health care, social participation, intersectorial action, people-centered model of care. There have been an important increase in public expenditure between 2005-2010. We see few points in the Latin American and the Caribbean. Some ministers will say to increase at 0.1 in health expenditure means a lot. And definitely is still a challenge in the region, and we will see later what the proposed actions are. Countries have made tremendous efforts to improve health financing, not only in terms of improving the amount of resources that will go to public expenditure, but also the quality of that financing and that expenditure, looking for opportunities to improve efficiencies so that you can realize what is the equity in the financing. Now, the region, with all of that and with a lot of experiences and lessons learned, still is a region where that is classified as the most inequitable region in the world. So that means that economic growth and progress have not really permeated to all according to needs. And that is perhaps the main challenge that the region faces in the 21st century in terms of how now we move to further expansion of the principles of the Alma Ata Declaration that are still very valid. Some examples of that in the health situation you will see here. This is the inequality in income distribution in different countries, and this is how that affects the infant mortality. And we will see the big gap, inequity gap for infant mortality between like Cuba and Haiti. And definitely that is an important challenge in the region. The region has reduced tremendously the maternal mortality, but we will not be able to achieve the Millennium Development Goals in that area because we have several countries that really are totally lagging behind. On top of the inequity situation, there are the challenges of the new demographic changes and the new challenges for the health system, that the chronic non-communicable diseases, which really will be impacting not only the financing of the health systems, but also need responses that are not the traditional responses in the way that healthcare delivery is organized, that is more acute-based, hospital-based than comprehensive and long-term. And the chronic non-communicable diseases, along with the changes in the demographic patterns, are really add complexity to the issue of how do countries deal with inequities in health. We also have an important explosion of violence and all different types of violence, but including gender-based violence. And here is some statistics in terms of mortality rates due to road traffic accidents, where we know the capacity of the health system in terms of prevention is very limited and need intersectorial work. And we do have inequalities in healthcare access and use, specifically still the persistence of barriers to care and exclusion of the most poor and vulnerable to specific services. And here, for example, we have the mortality, infant mortality, and the 5 mortality rate compared between the general population and the indigenous population. So that challenge of how to reach the more remote populations and also the different groups in conditions of vulnerability is still persists, and that is not only for Mexico but really across the region of the Americas. And this is like the same picture that was presented for Mexico. One of the important challenges really is the segmentation and fragmentation of the health system, that it really becomes like a cycle. You put more money, but it's very inefficient, and then you need to put more, but you are not reaching your health objectives because you are not really creating conditions of efficiency. And this is really the situation. This is one country, but if you go in the different countries, pretty much we find a variety of the same problems: segmentation and fragmentation in terms of the financing, in terms of the delivery of services, and in terms of how we put together the resources for better health outcomes. And the same issue, availability of human resources. We still have a challenge in terms of the quantity, the distribution, and also the competencies of the human resources for health. And let's go beyond doctors, because definitely we know that the human resources for health include a lot more than doctors. And yes, there is a history in the region of even dealing with community health workers and non-traditional health workers, but somehow that is not necessarily well articulated at the moment. And the professional health workers still in deficit in many areas. With all of that, as you know, member states, as they do for WHO, also in PAHO, in addition to the participation in the development of the global program of work, develop the strategic plan 1419 for the region of the Americas, which really identify universal health coverage along with the social determinants of health as central pillars of the plan, with the people-centered health approach that really guide strategically the plan to around specific impact goals that have been agreed upon by member states. And based on that new opportunity to identify not only challenges but also opportunities and how to move forward, the member states requested the Secretariat to move with the development of a regional strategy for universal health coverage. And what is really the demand from member states is not necessarily that we are coming with any new thing, because still we are really working based on the history. But what is new in terms of the universal health coverage agenda is how we can reinforce and also expand based on lessons learned, and how can we overcome the bottlenecks that were present in the past. And then it's a little bit of looking at universal health coverage as an objective that guides transformation of the health systems. And that transformation is really aiming that all people and communities have equitable access to needed, comprehensive, quality services that are guaranteed and can be demanded throughout the life course and without financial hardship. Now, this is a definition that has many elements. Some people will say, well, just reduce that and say comprehensive quality services. No, there are several values there that need to be put into perspective, because what is really the new thing and based on lessons learned? Universal health coverage and access to services for all cannot be services for the poor and with different services for the poor of different quality. That concept is a concept that really member states want to overcome in the region. It's the right to health, but it's the right to health for all. Quality means quality for all. That doesn't mean a country is going to take in one shot all services. That means that is the vision, that's the value, that's the core center of the universal health coverage that all member states really are committed to. And then each country will need to develop how they transit to that in a progressive way. But at least the values that are really same values for the Alma-Ata Declaration are renewed in the sense of making the right to health now to go beyond the Constitution and be clearly translated in the commitment of defining what that means in terms of the set of services that are going to be ensured, guaranteed for the population with legal and regulatory frameworks. That means equity is at the center of the transformation of the health systems. And therefore, to achieve that, we need to really consider definitely social determinants of health. And solidarity with the concept that has not changed, but that needs to be translated now in how we finance and organize our health systems. And that means people that have more give more, and people that have less contribute less, but the distribution is according to needs. So that value of solidarity is an important one to reaffirm. And at the moment, this is a process that is really in development. It's work in progress. We have just initiated the consultations with member states, and that, of course, will shape the final way in which the strategy will be developed and perhaps presented to the governing bodies. But there have been now 4 strategic areas of focus identified that are being put to consultation with member states. The first one is in a strategic line of action that is really seeking to improve equitable access to comprehensive quality services that are people and community centered. Important to say that the identification of quality services and the definition of services for the region involves both interventions that are population-based and individual-based. They strengthen the stewardship and governance of the health sector to be able to effectively implement and improve equitable access, increase and improve financing, and specifically the call for eliminating direct payment at the point of service with equity and efficiency. And that means moving to a consolidation of funding, and also intersectorial action to tackle the social determinants of health. And we want to really emphasize the importance of the addressing the social determinants of health in the context of universal health coverage, because as we saw in the previous presentation, and we can see in the health situation, unless we can address the social determinants of health, universal health coverage will not be a reality and will not be sustainable. So how to really improve the health sector capacity and the leadership and the stewardship of the national health authorities to influence other sectors that will need to really guide their interventions to address those critical determinants of health, like education, like access to basic services, and other determinants, the cultural and gender norms. And I would like to really finish my presentation with the statements of 2 powerful women in terms of universal health coverage. One is our DG. I was just mentioning that it's interesting because when we go back to Alma Ata, basically the leadership and the driving force were predominantly men. In this new universal health coverage agenda, we have seen also that historically we have seen a shift in terms of also more women in leadership positions. And I was in a meeting in Peru a month ago, and the opening panel was the Minister of Health, a woman, Margaret Chan, a woman, Carissa Etienne, Director of PAHO, a woman, and the MC was a woman. So I was like, wow. And then in the same place, we had Dr. Tejada, who was a leader in the Alma Ata process and in the development of primary health care, also present in the same meeting, bringing that perspective. So it's interesting to see how the processes have evolved. And the 2, I will actually read the statements because it's really a quote from Dr. Chan, and it's a UHC, Universal Health Coverage, is the most powerful unifying single concept that public health has to offer, because you can realize the dream and the aspiration of health for every person, irrespective of what class you belong to, whether you are a woman or whether you are poor. And then, complementary to that, Dr. Carissa Etienne favorite phrase when she talks about UHC is each country needs to find its own way to universal health coverage, its own way, based on the agreed upon principles, on its own particular historic, social, and economic context, promoting a large social dialogue. And every country can do something to move towards universal health coverage. So with that line, I thank you for your attention, and I will be happy to answer questions.
Okay, well, thank you, Dr. Amalia, for your presentation. And now I'll hand over to my colleague, Dr. Sanjoy Bhattacharya from the WHO Collaborating Center for Global Health Histories at the University of York, who will moderate the question session.
So I'm Sanjoy Bhattacharya from the University of York, and those of you who attend this event regularly, forgive me for boring you with the same request that when you make your comment or ask a question, please identify yourselves, because we often have online attendees who would like to know who you are, and it's always good to increase communication between people in this room and people out there all over the world. We also place recordings of these events on the WHO website. So believe me, if you leave your name and number, so to speak, someone will be listening to your comment, and I'm sure you'll get interesting questions and comments in return. As someone who has the honor of chairing two terrific papers, thank you so much. I've learned a lot. I have two very quick questions. I mean, intersectoral cooperation comes up a lot in both the papers, but in different ways. But that puts the onus, I think, on governments. What about interagency cooperation? I mean, is that going to be important in the future? Has that been important in the past? Because clearly there were more than one sort of international stroke global actors in the field. And secondly, I think personally, from a personal viewpoint, one of the great strengths, I think, of the universal healthcare message that's coming out now, the universal health coverage message that's coming out now, is that countries are being encouraged to come up with their own model, as we had in the last quote. And I think that's very important. What is less clear to me is whether such a message is coming out in relation to the social determinants of health. And this is therefore mainly a question for our WHO colleague. Which, despite its claims of trying to increase health equity, seems to me, as an independent critical view from the outside, to be a very top-down process. So how do you reconcile a top-down message with a bottom-up message, so to speak, and bring them together so that they work very strongly together? So please. Yes, please.
So thank you for that question, Sanjoy, about interagency cooperation. I think you hit the nail on the head. I think that is one of the major problems. In the rural areas, in particular, what we had was two health systems, the FFA and the EAMS, and often people on the ground don't know which ones they should go to. So what you have is a lack of understanding, even among the patients, of where they should go. And this, when you talk about cooperation, that is the key word, because there has been a lack of cooperation between these agencies. And a big part of it is that they get funding depending on the number of patients or the number of people who are coming to see them. So each is protective of their own space. So the complex health system that both Amalia showed for Guatemala and I showed for Mexico is one of the roadblocks to creating a much more comprehensive universal coverage in the countryside. I don't have an easy answer for that, but I do know that it's a clear problem and one that comes often. And to my knowledge, you may be more aware of this, what solutions have been attempted, and I'm not aware.
Yes, I think we are talking about two different aspects. One is the one that is inherent to the National Health Authority in terms of governance and regulation, which is an important element in terms of how to really make the health system to operate in a coordinated manner in what we will ideally envision as a comprehensive network for service delivery. And that is a function that needs to be performed by the government, by the state, because no one else can do that, and that cannot be delegated. And another one is the need for, we talk about intersectorial action, but we want to expand that to processes of social participation that will involve different sectors and different stakeholders and the civil society in shaping the health agenda in the country with clear mechanisms for accountability. Because one of the, we have seen in terms of lessons learned that those countries that have really advanced the most in the region are the ones that have been, I will not say that have developed, because this is not only something that comes from the government, it's now coming from a demand from people that they want to be more actively involved. So like Costa Rica, we had the Minister of Health the other day saying, I needed to find a mechanism to involve the civil society and the stakeholders, because they are now demanding new things. And there is a tension between what the health system can offer and can afford and what now the population is demanding. So that need to really involve the people and different sectors, and also that need of strengthening the capacity of the National Health Authority to influence other sectors. There is no one size fits all, but clearly what we are seeing is not necessarily that each country develop their own model, but that each country will develop the how they transit to the ideal of universal health coverage, identifying some key elements that we are calling like almost prerequisites in a country to say that, yes, what you're doing is moving toward the universal access agenda. And how the health sector can also advocate in the social sector to ensure that there are complementary actions like the cash transfer programs that will really be attending the most vulnerable and excluded population.
Wen Zhao from WHO Service Delivery and Safety Department. Very nice to hear the presentation from Mexico about the primary care and uneven development. So this reminds me to think about, the situation of China, which also, with this rapid economic development, but there's also social stratification and uneven social development. So that's the issue of China. Last week, I listened to Farid Zakari GPS talking about U.S. case. U.S. has the per capita investment on health 8,000, but the social progress on health is ranking 77, I think, from last week. So you can say, for both countries, even Mexico, I think economic development is fast, but social development is significant or even polarized. Look, here we mention Mexico, you see the poverty program, whatever, a sociological perspective. But if now the Mexicos, the social equity is deteriorated, also improved. That's my question.
Yes. So your question was, has the social situation improved?
Yeah, overall in Mexico.
That's a really interesting question. You may be aware that in the fall, this image circulated, a very disturbing image of an indigenous pregnant woman who was not allowed to go into a clinic because it was not yet opening hours and she was about to give birth. And she was forced to give birth on the grass outside of the clinic because she couldn't wait until 8 a.m. when the clinic opened. And this was just a few months ago, and this was in the state of Oaxaca. And it was in one of these clinics, which I'm talking about. So your question is very poignant because it addresses the fact that we can create these physical structures. We can create these clinics. We can take the doctors and nurses and health promoters. But if there isn't a change in mentality with regard to a question of equity, but also of human respect, and that health coverage is about dignity, the dignity of the patient, and it doesn't attend to schedules. And to so that mindset is still there, unfortunately. And I have no clear solution to how that would change, although I have an idea. And I've had this idea from studying the sanitary reports over the course of the 20th century. And I think the mindset needs to change before they become physicians, so at the level of medical schools. So to begin to create in medical schools this idea of social obligation that they're then required to do, but that doesn't really mean anything, or how that's translated. Everything from a manual. What happens if? What happens if your patient believes in the evil eye? What happens if your patient comes to you with homemade remedies, and to not disdain but rather incorporate, so that we don't have situations such as the one I described, which continue to happen, and it's a complex problem. So unless that is addressed, it doesn't matter how much money is put into the healthcare situation, the changes will be slow in coming. Thank you for that interesting question.
If I may, because complementary to the issue of to the issue of the training of health providers and all of that, we know also that they have been a failure in specific interventions that will make health systems more responsive to all of the issues related to respect to culture, and also the issues related to other barriers in the health systems, and how to create incentives and a work market for a new a set of professions. For example, family medicine is still something that is considered, at the end of the spectrum in the medical profession. What are the incentives and the changes that countries will make to ensure that that is recognized, not only in terms of credibility, but also in terms of remuneration and benefits? The way we, for example, develop the incentives and the mechanisms for purchasing of services, where it's based on amount of people seen and not based on health outcomes. Of course, if it's based on amount of people seen, if I see 100, I'm going to get my better payment, but not necessarily linked with quality and the health outcomes. So there are instruments that can be used but of course that needs to be part of, again, a comprehensive response.
We have a question from the University of Toronto in Canada. It comes from Professor Anne Emmanuel Byrne, and she asks, what was the role of Cardenia's Ejido collective farming system and its medical services in increasing access to healthcare in rural areas? And then she has a question for both of you, which asks, what have been the challenges around incremental and patchwork reforms for universal health coverage versus broader reforms that seek to create unified health systems?
So first I want to say hello to Anne Emmanuel Byrne. And so the role of Cardenas Ejido system and its medical services in increasing access to healthcare in rural areas, it's a really interesting question, because the ejido, or collective farming, which was this notion that the value of the right to land, to own land, that was given in the Mexican Constitution, which I mentioned, was given to these farmers as collective ownership, meaning that as a group of farmers or ejidatarios, that they would collectively own the land. So when it comes to, there were a series of programs like the collective ejido reform that was sent to rural areas, and that used the ejido as the launching pad or as a form of organization for health projects. So to completely address your question, Ana Manuel, the ejido becomes the blueprint from which to gauge the success of specific medical programs and the way of distributing health. In the 1950s, we see that a lot of the gauges that are taken are based on progress in specific ejidos. So if the village system stops being the norm and it becomes the ejido system. Let me read the second question. Do you want to answer that? I haven't read the second. Can I get back to that?
Yeah. Yes, and what have been the challenges around incremental and patchwork reforms versus broader reforms? There are many challenges, but maybe I can give a concrete example for one of to me, the most important challenges is the lack of an integrated approach. I will take, for example, Jamaica. Jamaica, a few years ago, implemented an important reform, which was eliminating user fees at the point of care. And it's one of the recommended interventions to really overcome barriers to care, because we know that financial barriers are important in access, in facilitating access to care. However, the challenge was that intervention was not accompanied by a comprehensive set of interventions that will address, one, how you will substitute the financing, two, how you will prepare the health services to actually cope with the increase in demand, because of course if you remove user fees, you will expect an increase in demand, and then the health services were not prepared. How do you increase the capacity for the health authority for regulation, where you have an important participation of private sector in the provision of care, so that really when you go to different countries and you will identify the challenges about what you call the patchwork, they are very clear. However, there are challenges also in trying to introduce broader reforms, because as I mentioned, in the majority of our countries, we have reached a reality which is there, which is a big segmentation and fragmentation of the health system. So how you bring about comprehensive, even in some countries, we cannot even talk about unified health systems. Maybe we can talk about coordinated, regulated health systems, because the reality right now is quite complex. That will require some very tough political decisions that not all the governments are willing to really take. But despite the challenges, what we really think is that there are a set of things that need to be addressed in a sort of interdependent and simultaneous way. That this is not, I move with one line of health financing without taking care of interventions to improve access to care, and that the governance issues and the stewardship need to be part of that plan, and that you need to also have to consider the social determinants of health. How? Generating an important social dialogue that then can help the country to shape the response. That the social dialogue and accountability becomes then one good practice to overcome the challenges that for both going with a standalone patchwork incremental or a broader reform. That will be.
Ed Kelly, I'm in the Service Delivery and Safety Department, and we're very pleased to have Amalia here. She's our focal point for the Service Delivery Network this week. My question is for both, and first of all, thank you for both presentations. They're extremely informative. And I wondered about, both from WHO's perspective as an institution that promotes the data and the use of data, as well as from a historical perspective, because you presented, Dr., like a very interesting picture of the sanitary reports and their role in highlighting some of the barriers to this. Within the area of primary health care, obviously data has a very particular, there's particular issues with it that's quite different from the hospital sector and other sectors. And my own feeling on these equity issues, if the countries that have made the most progress on this have developed ways of assessing vulnerable groups and really targeting them. So I just wondered if you might comment on that from Mexico's point of view, and also then maybe within the context of universal health coverage, how we might surmount that, what the particular data problems are with primary health care extension.
So thank you for that question. With regards to the sanitary reports, you're absolutely right. Data determined where healthcare delivery was going to take place. And this had initial repercussions, as you see from some of the sanitary reports. Some of the medical students were quite eloquent in their description of the situation of the locale where they had been sent. And they were able to pinpoint the need for roads, or the needs for electricity, or the needs for a sewage system. But others weren't such good ethnographers. And what this translated to was areas that might have needed more or faster or more urgent services were not necessarily approached initially or in a certain fashion. It determined the type of delivery, but also when it would be delivered. So what these young medical students were doing were translating the countryside for policymakers and for politicians, but that's not what they were trained to do. So much of that data was also tinged with their own personal understandings and prejudices, but also their changing understanding of the countryside. And I think just to add a final note on data, that becomes probably the most complex thing for Mexico, and that's what it attempts to tackle in the 1980s with that series of reports, because they find that even finding concrete numbers or factual evidence of what are the diseases, what people are dying of, is difficult in and of itself. And as you know, if you don't have those numbers, it's difficult to create programs around them. So yes, the sanitary reports in and of themselves created new questions and new quandaries while illuminating some of them that were already there.
Yes, from the universal health coverage perspective, the strong information systems and robust information systems is one of the key elements of to be strengthened for governance and stewardship. Because as you properly mentioned, we do have a gap in terms of available data to inform decision making. So that becomes an integral part in what we are considering now as a regional strategy. This is like one of the key elements to reinforce in governance and stewardship. And it's the information systems that can account not only for morbidity and mortality related to, disaggregated by age, sex, but also that can inform about inequities and how there is progress toward, reducing inequities or not. Another element in terms of information is that of generating evidence to advocate for the development of other programs and specifically outside of the health sector programs like social development programs. That is pretty much linked to one of the strategies for the health in all policies that calls for evidence to support advocacy and decision making in the social sector, and specifically evaluation of the impact of different social or programs or interventions in health. So that's another piece which we consider part of a key element for the strategy in terms of improving intersectoral collaboration to address the social determinants.
My name is Adelaide Onyango. I work in the Department of Nutrition here at WHO. And thank you very much, both of you, for excellent presentations. It was a pleasure to listen to all the information you provided. When you in the nutrition area, we are not actually. We have been looking at what is health and what is a disease, because when you're dealing with diseases, it's something that you're trying to prevent a disease, you're trying to prevent malaria, you're trying to treat malaria. That's a nice one. But what about when it's actually health? When you want to promote health, give health, so that in fact you step away from the treatment. How do you take that into consideration with this universal health coverage? Because we're talking about clinics and so on, but what about, because then it really takes you to the social determinants and the very, very wide range of areas that are necessary for health to be guaranteed.
Yeah, that again, in two ends. One is the end of the provision of services. I mean, a comprehensive services means that you will really also include the elements of health promotion and prevention in the provision of care. And so we don't need to wait until the person develops diabetes to do a good clinical assessment and know that I have history of diabetes, and then, you know, if I have regular checkups and whatever, my health provider should be looking and educating and whatever. So the health, the organization and the content of the comprehensive health services implies that we incorporate that spectrum in the provision of individual care. And the other component is empowerment of individuals and communities to understand health, to understand it's a little bit of what have been called health literacy programs, and it's more used in some specific program areas, but how individuals can understand health, can understand what are the rights and the responsibilities, and also what are the social determinants of health, and that is more targeting now the communities, the leadership in the communities, to understand the social determinants of health and how they impact health. So that is, again, a critical element to be considered when we are talking about expanding access to services in a comprehensive way, and also addressing the social determinants. I'll
answer with a quick example, because in 2011 I was in San Luis Potosí visiting one of IMSS Oportunidades clinics, and I happened to be there when it was a nutrition class, a nutrition day, and it was really clear how one attempts to translate health to the local experience. And what they were doing, they were meeting in the hospital, but a wing of the hospital had been transformed into a larger kitchen. And it was there where men and women met. And it's very easy to say, we all know that we're supposed to eat fruits and vegetables over candy or chips. But what they were doing there was giving concrete recipes and having people cook them there using local fruits and vegetables. So, or herbs from the countryside that you could bring and find the nutritional value. So to me, that was a very important example of how a much larger concept of health, that we all know that we need to eat well to live longer and to live healthy lives. But what does that mean? And here it's giving people not only the knowledge, but the actual tools to teach them. And for me, that was probably one of the most poignant examples of what it means to lead people so that then they can understand, because it's not simply giving them the knowledge of what to do with it, but actually teaching them how to do it.
And I just want to compliment, because I forgot, I think, something that is also very important that has to do, again, with the governance and stewardship of the health authority. And it's that of creating enabling environments. It's really like a legislation for tobacco use that is very controversial, but will have probably more impact in terms of addressing the risk factor of smoking, a legislation to regulate trash, we call it trash food. I don't want to really mention names, but some for example, some governments will have specific regulations for healthy cafeterias in the school, or healthy the Healthy Schools initiative, in which you really promote exercise, and so enabling factors that also can help to complement that individual or community effort, because we know that at the end of the day, you can really know that you should not be eating trash food, but the vegetables are expensive, they are not available, the marketing and all of that also influences individual behavior. So it's a complement of exercise.
Thank you very much for your presentation. I'm Gabriela Estrada. I'm in the WHO in the Public Health Innovation Department in Intellectual Property. And I would like to ask about accountability. In terms of universal health coverage, you have said that, well, it's responsibility of the government to create a universal health coverage. However, sometimes when you want to measure accountability and the quality of the services, the government cannot be the provider and the person who is to measure the quality. I would like to know how NGOs or how WHO could generate or support this branch who can create organisms or groups that measure this accountability and this quality of services, or the PAHO.
I could ask Efu to help me with this, but in our region, number one, I think it's important to clarify that universal health coverage is, as an objective, is really, if we take the right to health as a constitutional element, then it's the state responsibility. Governments really will represent the state. One, and two, that yes, of course, the government and the health authority has the responsibility to lead or coordinate a national effort. But I think it's important to emphasize the social participation and the establishment of mechanisms for accountability. In many countries, that is shaping in the form of what they call foros de salud, which are a group of civil society, citizens, organizations that organize around health, and they develop a specific mechanisms for accountability. So in many of our countries, it's not now a government a structure or mechanism, even though the government will have their own mechanisms to support the intersectorial and participation, social participation, like in the forms of national health commissions and things like that. But yes, we see that as part of what is the need of generating transparency, dialogue, and meaningful social participation in the process towards universal health.
I think we've gone well beyond allocated time from the library, but it's a sign of how wonderful the two presentations were and how much interest it's stoked. So I'd like to thank the two speakers who've come a very long way to join us. And despite all the jet lag they're suffering from, there were two wonderful presentations. I'd like to thank our WHO colleagues, all of whom have attended this meeting, and thanks, of course, to the Wellcome Trust, whose support makes this series possible. We have another interesting case study next month on primary health care in Nepal, Himalaya, and South Asia. And we're inviting an academic from the University of Otago in New Zealand to come in and speak to us. She's written a very powerful book on healthcare among the Sherpas, a very topical topic right now, considering the Sherpas are planning to go on strike because of lack of medical insurance, health insurance, and healthcare facilities. So do join us if you're free. Thank you very much to the speakers.